Hello, hello, hello. Good evening. Um, if you can get my audio, just react. Send me an emoji, thumbs up, something on the screen. Thank you so much. Karibuni sana, karibuni sana. Welcome to this evening session, part of our bi-weekly webinar series. I am buying time to allow for more of our colleagues to join. So if you know a friend, a workmate, or someone interested in this topic for today, kindly just remind them that we are beginning and would like to all be on the same page and not leave anyone behind. In the meantime, I want to appreciate the reaction that I'm seeing on the chat box. Kindly let me know where you're joining from, county that is, so that we see who is in the room with us. Thank you so much. Susan from Nairobi. I see there's David Were from Nairobi as well. Karibuni sana. Karibuni sana. Judy Kemunto from Kisii. Karibu sana. Thank you so much for joining us this evening. Yeah, I see there's good representation from across the country. And this means, well, at least we have a session for professional capacity development that is cutting across the country. Thank you so much, everybody. I see there's Abigail from Western Gishu as well. Karibuni sana. Yes, maybe just to introduce myself, my name is Silvanus Manyala. I serve as the Communications Associate at PSK, and I'm pleased to moderate this session tonight. I'm joined by very worthy speakers who I will introduce later on in depth. But just from the snapshot, as you can see, we have Dr. Victor Mulelo, who is a health policy and systems researcher from the Strathmore University Prism Center, and Dr. David Olpangs, a PhD fellow, Health Economics Research Unit at the Kemri Wellcome Trust. This session is CPD accredited, and we encourage you to, of course, do the needful, which is subscribing on the portal, and of course, claiming the tokens that will be awarded to you subsequently. Maybe with that brief introduction, I just want to highlight that this session is brought to you by the PSK's Innovation, Research and Digital Health Sectoral Committee. And it's one of the first for many. Again, context for this will be shared in a few. And before you are noting is that we have this session running for the next few minutes. Ideally by 8:15, we should have closed the session, and a few announcements afterwards. Things to note and remember, again, as standard, is that you will remain muted during the session as a participant. We encourage you to use the chat box for general remarks and interacting with other participants and also the speakers. If you have questions, concerns, or you need clarification, you utilize the Q&A pod at the bottom of your window. So on your screen, you'd see a Q&A icon. If you want to raise a question, please raise it there, and we will be happy to guide the speakers to respond to you. We have this session recorded, and we'll have the recording uploaded on our YouTube channel. So if you'd like to revisit the conversation again, there's an opportunity for you to always go back and go through the session. And of course, we remind you that this session is CPD accredited. Maybe at this point in time, I want to Again, just still see who has joined us. If you joined in the last few seconds, we want to know where you are listening in from, which county. So kindly just chat us on the chat box. I see David Namu from Machakos, karibu sana. Lydia Ombok as well, karibu sana from Migori. We have Patrick Maina from Trans Nzoia County. Thank you so much. I want to, at this point, just highlight a few things before I invite Dr. Clinton to give us an opening remark. Again, as I had highlighted in the beginning, this topic is intentionally curated for pharmacists because we increasingly are contributing to sort of beyond what is known as the traditional practice of dispensing medicines and supply chain, but now more into roles in the broader health system functions. We have early career professionals and students who have limited exposure to health policy and systems research, and this is because of course, the lack of a structured career and research pathway. So this session tonight is an opportunity for us to be guided through in a timely manner. Again, this is very relevant given the platform we have, and we want to understand how the technical training for pharmacists can be translated into policy relevant research. This session as well will help demystify health policy and systems research by, of course, showing us the practical journey for those who have gone through it, as you can see from the speakers, and of course, entry points, mentorship opportunities, if any, and of course, how evidence can influence health policy. And Dr. Clinton, if you can hear me, I want to give you the floor for you to talk to us. Clinton is the chair for the Innovation, Research and Digital Health Sectoral Committee.
Yes, I can hear you. I hope I'm audible enough.
Yes, we can hear you. Maybe just raise your voice a little bit higher, just a notch, and then we should be good to go.
Okay, that's in order. I guess I'll try to shout. So let me know when you're ready.
Yes, go ahead.
Or when. Oh, okay. So my name is Dr. Clinton Osembe. I'm the chair of Innovation, Research and Digital Health Sectoral Committee. So we are going to have a series of webinars, and these series have been, if I might just say, how we came to arrive at these. We did a systematic mapping of health policy and research gaps through, number one, a desk review internally. The research wing was able to, led by Dr. Olpengs, was able to take initiative on that. Then we also did send a questionnaire administered to all members, all PSK groups. The response was a bit dismal, but we operated with what we got, and we decided, okay, through the findings, then let's make an informed two-prong approach to tackle this. So we designed a webinar series to address priority knowledge gaps. And we also have a thought leadership initiative in the pipeline where we have collaborated with the YPG, a few of them who are interested in research, so that we can generate commentaries for publication in peer-reviewed journals. It could be, we could start with publishing internally, of course. So this is part of a broader strategy to strengthen evidence-informed policy dialogue, to build research capacity among our members, and also promote pharmacy-led contributions to health system strengthening. With you tonight, the panel is full of experts in health systems research. I'll let Dr. Manyala and the speakers themselves to introduce themselves, but they have a rich profile that I believe members are going to benefit immensely from. And the students who are also with us, karibu sana. I hope we'll have an amazing session and series all together. Thank you so much.
Thank you so much, Dr. Clinton. I think that was very comprehensive, even with a short time to just introduce the whole series and the idea behind this series of webinars that we'll be having and supporting. Maybe at this point, I'd like to invite Dr. Victor Mulelo, who, as we had mentioned earlier, is a health policy and systems researcher at the Strathmore University Prism Center, and a digital health policy analyst with a very strong interest in the policy, regulation, and financing of digital health. His work focuses on generating evidence to strengthen health systems through better governance and informed policy making. He currently supports research on the regulation of e-pharmacies in Kenya and India, examining how online pharmacy models compare with global best practices. He also contributes to strengthening health workforce governance by analyzing the health workforce information systems and supporting the development of evidence-based workforce planning and policy solutions in Kenya. Of course, today he will introduce us to health policy and systems research and explore its relevance to pharmacy practice. Karibu sana, Dr. Mulelo.
Thank you
Let's
very
confirm
much,
you can get my audio. All right, perfect.
Dr. Manyala. So good evening, everyone. I hope I'm audible enough. So today I'll be the first of two speakers to take you through health policy and systems research, essentially trying to answer what it entails. And am I audible? I see someone saying there is no sound. I don't know whether that's on my end or their end.
We can hear you, Dr. Mulelo. I think that's on their side. Maybe proceed and then we'll try to address them on the side.
Okay, no problem. So as I was saying, I'll be the first of two speakers. We'll be taking you essentially through what health policy and systems research entails and why it's important. So what exactly do we mean by health policy and systems research? If you look at clinical research, it investigates the safety and effectiveness of new medicines and technologies. Biomedical research seeks to answer how diseases develop and progress. And pharmaceutical research is aimed at understanding drug development. So that poses the question, what exactly do we mean by health policy and systems research? Next slide. Yeah, so to first understand health policy and systems research, we need to understand the 6 WHO health systems building blocks. These are service delivery, health workforce, health information systems, medicines and technologies, health financing, and leadership and governance. And the pharmacist is uniquely placed because he or she is the only one who can serve across all 6 building blocks. So what do I mean? When it comes to service delivery, essentially the aspect of drug dispensing, medication therapy management, and pharmaceutical care and counseling is what is entailed in this particular section. Then when it comes to the health workforce, we're talking about the distribution, training, and retention of pharmacists within the workforce. As for health information systems, here we're essentially talking about the digital tools that facilitate exchange of information. So pharmacovigilance reporting systems, logistics management information systems, which I'm very sure those working in the supply chain and vaccination space are quite familiar with, health workforce information systems, and digital health and e-pharmacy. So digital health is interesting because it can easily be classified twice under health information systems and medicines and technologies. What do I mean? This is because you have the intervention itself, that is the digital technology, and you have the systems that support and run it. Because how these systems operate is that they rely on exchange and storage of information. And that's why you will see that they've essentially been classified under 2 building blocks. Then, of course, we have medicines and technologies, which as pharmacists we are well familiar with. And we have health financing, which is essentially how a country collects, pools, and spends money to pay for health services. So when you hear SHA has come up with this particular benefit package for its members so that they only pay a certain amount for certain services, that is the kind of thinking that goes into that particular aspect. And it's closely linked to the other building blocks because it affects service provision, it affects the prices of medicines and technologies, and so on and so forth. And then you have leadership and governance, which is where policies, legislation, and regulations sit. So as you can see, pharmacists have a role to play in each of these building blocks. Now, looking at these 6 building blocks, you can essentially do that from 2 perspectives. The first perspective is systems thinking, where you're essentially seeking to understand how these particular building blocks relate with each other. Then the second perspective is health system strengthening, whereby you are seeking to improve the relationship between 2 or more building blocks. And the 2 are intertwined because you can't have one without the other. For you to carry out health system strengthening, you first need to understand what it is you are strengthening. And unfortunately, systems thinking cannot exist in isolation because now the question becomes, then what? After you've understood how these particular building blocks operate, then what? So that is the sort of delicate relationship that the 2 have. And I can give an example. When you talk about the relationship between health workforce and service delivery, for you to ensure that your patients are receiving optimal quality care, you need to have the right people with the right skills at the right place offering a particular intervention. So that means if a facility is understaffed, then it goes without saying that the quality of care that will be provided will be suboptimal. And that is just an example of how this particular building blocks relate. When it comes to health financing, money runs the system. So how do we ensure that whatever is coming in financially is sustainable enough to maintain the system? Next. So now, how do you translate whatever we've just said to actionable insights? And I have here a flow diagram from 1 to 7 that will take us through this. So the first one is observation. You notice a problem in practice. It doesn't necessarily have to be a problem. It can also be an opportunity. So for today, let's be optimistic and think about opportunities. And I'll use an example of work that my colleagues and I have been doing at the PRISM Center for the last 3 or so years, which involves the assessment of online pharmacies. So online pharmacies are not a problem, they are an opportunity for expanded coverage and increased access to pharmaceutical care. So then comes the next step, the research question. Why is this happening? If you look at the history of online pharmacies, they gained prominence during the COVID-19 era. This is because of restrictions in movement and essentially the lockdowns, which necessitated people to be creative with how they deliver pharmaceutical care. And the market embraced it because of the convenience that also comes with it. So now the question becomes, if I am to go to an online pharmacy, will I receive the same quality of care that I would in a traditional brick and mortar pharmacy? And there are certain regulations that govern pharmacy practice. Do online pharmacies adhere to these regulations? So now, how can you find out? You investigate. And we were seeking to understand, one, the level of adherence and compliance of online pharmacies to regulations authored by the Pharmacy and Poisons Board, and 2, the quality of care that we would receive in an online pharmacy and how it will compare to a traditional brick and mortar pharmacy. So after the necessary approvals, we ventured out as mystery shoppers, and we essentially tried to purchase a series of drugs from these particular platforms so that we can document that experience and try to better understand it and have areas for improvement. And I won't dwell much on that because We did an episode on the podcast that is Inside the Capsule. I think it will be coming out tomorrow at around 1 p.m. So watch out for that so that you can better understand what are some of the findings. Now, once you have the findings, what does the evidence show? One of the things that came out so strongly was how easy it is to purchase an antibiotic without a prescription. Yet we know these are prescription-only medicines. So now that we have gathered this evidence, what do we do about it? That brings me to step 5, 6, and 7, which in my opinion is the most sensitive, because now that you have all this wonderful information, what are you going to do about it to ensure that there is sustainable impact? So what should be done? What we did was first had a sit down with both the non-government stakeholders and the government stakeholders. This happened sometime last year in November, essentially to try and understand what are their perspectives with regard to the online sale of drugs and how these perspectives can be improved based on the findings that we established. So after a series of deliberations, we actually sat down and discussed the current guidelines for online pharmacy services as they are, the potential shortcomings, and the areas for improvement. And this is a work in progress. It's something that is still ongoing, but essentially that is how we decided to go about it so that we can essentially have a bird's eye view of the problem, the solution, and how it can be incorporated into the health system. So health policy and systems research is the science of turning real-world problems or opportunities into evidence, policy, and action for better health outcomes. Next slide. Next slide, please. So now the question becomes, how do we study health systems? You've identified the problem or the opportunity. How do you go about it? So there are various ways of going about it. The first is conducting qualitative research, which essentially entails understanding experiences, perceptions, and behaviors. So an example is you want to interview pharmacists to understand the barriers to reporting adverse drug reactions to the Pharmacy and Poisons Board. And the potential impact of this is that you will strengthen Kenya's pharmacovigilance system and improve medicine safety reporting. That is, if you identify the reasons why there is inadequate reporting and how these particular problems can be resolved. Then you can have quantitative research, which is essentially looking at the numbers. So you can decide you want to do a survey across community pharmacies to determine the availability and affordability of essential medicines across Kenya. So this can inform medicine procurement, resource allocation, and also access to medicines, because by understanding why certain drugs are priced in a particular manner, you are able to look at aspects of accessibility and equity of access. Then mixed methods research is where you combine the two. You have both a qualitative component and a quantitative component. What do I mean? You want to look at stockouts of medicines across public health facilities, and you just don't want to look at the data. You also want to interview the pharmacists as well so that they can identify the underlying causes. That way, you are able to improve the entire supply chain and enhance medicine availability. Then there's something else called implementation research, which is essentially how interventions are being implemented in real-world settings. I'll give an example. Of late, there is the rollout of Taifa Care and Afya KE, which are two hospital management systems that are sort of related, with one built onto the other, that the government has been rolling out as part of its efforts to, attain universal health coverage. And there have been complaints whereby some people feel like the system was not adequately studied before it was rolled out. Some feel like it was rolled out, but it's inadequate in terms of functionality. So if you go out there and gather all these findings as to the challenges that these particular systems are facing and how they can be resolved, that is an example of implementation research. Then policy analysis is one of the components of the work that we are doing on online pharmacies, whereby you essentially want to evaluate certain policies and whether they are robust enough and they are meeting the purpose that they are intended to meet, or are they punitive and restrictive? Because it could go either way. It could be that the policies are adequate, it could be that they are punitive and restrictive. So once you've done that, what recommendations can you give to ensure that these policies or recommendations are better suited to serve the market? Then lastly, we have economic evaluation, whereby you assess the cost and value for money. I'll give an example. Right now, there's the pharmacy first intervention in the UK, right? And hypothetically speaking, if Kenya was to adopt such a system, the first step will be an economic evaluation. You want to look at, if we are to go the pharmacy first route, will we save on money as compared to traditional hospital-based care, or do we stand to spend more? If you realize we stand to save on money, you can actually make an argument to the Social Health Authority so that they incorporate this under the various insurance packages that they offer. Are we together up to that point? Next slide. So this is an example of another project that we've also been working on at the Prism Center. And essentially what we are doing is we are trying to map the end-to-end journey of the healthcare worker, starting from education and training to when they exit the health workforce. So from education and training, what is it that is happening that as things stand, what is it that is happening for the students who are pursuing healthcare related courses? Are we producing the right numbers? Are the graduates coming out with the right competencies? Then after education and training, you have the aspect of internship. Are internship opportunities sufficient, equitable, and aligned with workforce needs? Then there is the aspect of recruitment and employment, which is how new graduates and interns join the health workforce. How efficient is this particular process? How fair is it? And once they've joined the particular workforce, there's the aspect of deployment, where they are sent to various facilities. So are they deployed according to population health needs and the workload of the said facilities, or what guides the deployment? And then, of course, there's workforce welfare and retention, whereby we look at issues such as motivation and well-being, and essentially job satisfaction of those workers who are in the healthcare system. And then mobility and transfers. If I want to switch from Nairobi to Mombasa, is there a framework for that? If not, why not? And last but not least, the exit from the workforce through either retirement, migration, or death. So we're essentially looking at the entire journey of a healthcare worker, right from enrollment in school to when they exit the workforce. And some of the factors that influence this particular process are: one, HRH information systems. So having robust health workforce information systems in place will help you understand who is graduating from where and who is joining the workforce, how they've been deployed, and how they are exiting. Essentially, it helps with workforce planning and forecasting. Then, of course, there's health financing and donor transition. Like I said, the system needs money to run. Now, in the age of donor transition, we have the USAID stop work order that affected donor-dependent activities in the country. You have healthcare workers who are working in these particular programs. What happened to them? Where did they go? Is the government putting in place initiatives that will ensure they are reintegrated into the health system? And then lastly, but not least, we have essentially we have all the essentially, so the previous slide was to show how you can have one overarching project with several sub-projects, each feeding into each other. Because whatever you find out about education and training will influence everything else downstream. If, for instance, we are training an adequate number of, let's say, healthcare workers, then it goes without saying that we'll have people going to internship on time, the health system will be able to absorb them, and so on and so forth. So in as much as there are different components, in some instances, all these components can be combined into one overarching project. Next slide. So what are some of the key take-home messages? The first one is health systems matter because health outcomes are also influenced by how health systems are organized, financed, and managed. And pharmacists as stakeholders in healthcare contribute to each of the 6 building blocks and are therefore in a very good position to shape the future of healthcare. Over to you, Manyala.
Yes, thank you so much, Dr. Mulelo, for that comprehensive presentation. I know it's one that would attract even concerns and questions from the participants, and maybe just another round of a reminder that if you have questions for Dr. Mulelo, please post them on the Q&A tab. In the meantime, I want to again just switch us to the next part of the presentation, and we'll be inviting Dr. David Olpens, who is a researcher in the health economics and policy space. Currently a PhD fellow at the Health Economics Research Unit, and that is at the Kemri Wellcome Trust, where he has experience supporting health financing reforms, primary healthcare strengthening, digital health innovation, and regional policy dialogues in several sub-Saharan African countries. He's currently pursuing his PhD, as I've mentioned, in health economics with a focus on economic evaluation of non-communicable diseases care interventions. Karibu sana daktari.
Thanks, Manyala, for that warm introduction. And also, I appreciate Dr. Victor for cementing the foundation in enabling us to understand health policy and systems research. I'd like to begin with a simple thought. Every stock out, probably we have explained to a patient every medicine shortage we have tried to solve in our setting in the pharmacy space. Every time we have wondered why patients don't adhere to treatment. These experiences in itself have been exposing us to the health system in one way or another. But the difference between practice and research is not only what we see, but what we do with those observations. And that is the motivation towards my presentation. I'd like to walk us through how health policy and systems research is a pathway is a pathway that pharmacists are uniquely positioned to lead. And for my presentation, I'd be happy to discuss where health policy and systems research begins, how every pharmacy problem how everyday pharmacy problem becomes research, the skills and career opportunities that are available, and the practical steps we can be able to take to get into this space. And to begin with, a misconception is that health policy and systems research begins after postgraduate school, but I wish to demystify this by saying it actually begins with curiosity. You just have to start where you already stand, the problem you repeatedly experience at your workplace. It's often an excellent research question. It could be the irrational prescribing, it could be the delayed procurement, it could be the medicine affordability issue. This is a good base to start building your research on. Also, it's important to be able to build your research portfolio by experiencing and even attaching yourself to ongoing research, either through activities within it, including data collection, literature reviews, or even analysis of the data that comes in therefore. In addition, important to be able to formalize this experience and even to strengthen your methods through postgraduate training. This could vary from public health, masters in public health, health economics, health policy, epidemiology, implementation science, or even global health. But allow me to say this is not a detour from your base pharmacy degree, because it is this knowledge that you gain in pharmacy degree that gives you an understanding of the health system, and it's what serves as a foundation as you get into the policy space. Also, in addition to this, it's important to embed yourself within the environment of health policy through attachments, internship, or participating in technical working groups, just to experience how decisions are really made. Next slide, please. And to appreciate how this would practically work for pharmacists getting into research. So let's imagine a community pharmacy. Patients frequently request for antibiotics without prescriptions, and as pharmacists, we would simply deal with the situation the best way we know how to, and probably move to the next activity that we have for the day. But as a health policy and system researcher, the question you'd ask is, why does this keep happening and what can be done differently? This question by itself would be able to open several health system issues, including regulation, issues around incentives, access, patient behavior, and even enforcement. From there, the next step would be to select an appropriate design, as Dr. Victor alluded to, into the different design to answer your questions, to collect the data that would be able to give more insights into the question that you're trying to answer, and most importantly, to translate the findings that you get from the data you've been able to collect into recommendations for decision makers. The goal is simply not to publish a paper. The goal is to be able to generate evidence that changes policy. A scientific publication would contribute to academic knowledge, but a policy brief that follows this publication would initiate the process of presenting practical recommendations for policymakers and implementers. Next slide, please. Once you've been able to generate that evidence, the next question is, where can this evidence that you have been able to generate take you? And there are diverse career opportunities in the health policy and research space. Could be academia, could be within the government and the Ministry of Health, could be in the regulatory agencies where you'll be able to practice pharmacovigilance, medicine regulation, and such like. Could be within the research institutes and think tanks. NGOs and development partners are also a space. Health policy and systems researchers could be able to explore, and even the global organizations that are there. Equally important within the journey of a health policy and systems research is mentorship. You find that more opportunities come through professional relationships. Read my recommendations would be to read widely, identify researchers whose work align with your interests, and don't hesitate to introduce yourself to this. Also, funding opportunities are also key to steer the work that you're already doing or you want to engage in, from the university research grants, from conference travel awards, scholarships, international fellowships, or even competitive research grants. The key is to start small and gradually build your portfolio as you grow in this space. Next slide, please. So, regardless of where you choose to work, success would depend on developing the right competencies. And for health policy and systems research, okay. Regardless of where you choose to work, the success depends on developing the right competencies. And for health policy and systems research, it's sort of multidisciplinary. No one would begin with every skill set that I've been able to table here, and no one works alone. So the core competency areas are a combination of the research, analytical, and communication skills. The important message is, don't wait until you feel fully prepared or you feel that you have all these skills. Build your competencies progressively and collaborate with people whose expertise complement your own. Next slide, please. So even as you get into this space deeper, something that is also important is to build on your visibility. And you should think of visibility as a ladder. Conference abstracts would lead to presentations. Presentations would lead to you having refined thoughts on how to present your piece as a publication. Publications will later on create opportunities to contribute to technical working groups and even policy discussions. However, there are barriers into entering the health policy systems research, which are real, but they are also manageable. Many people would say, I've never trained for this, but neither are most people in the field. Most enter the field laterally, and the clinical or regulatory or even supply chain credibility are just the unique foundation that you need, but you'd enter the space laterally. And then one would also say, don't have enough time funding. For this, you'd want to start with questions that questions from your own workplace. You conduct a small audit, you analyze routine data, or you even undertake a focused secondary data analysis as a start, and then you build your portfolio from there on. Also, someone would say, I don't know anyone in the health policy and systems research, but networking is also part of the research bit of getting into this research. So participate in conferences, join all professional associations, and connect with the researchers whose work you admire. Most of the collaborations begin with a simple conversation. Also, one would say, my work won't influence policy, but it can only if you share it. When you present at conferences, again, I emphasize, you publish your findings, you develop policy briefs, and then you engage also the decision makers to be able to push your work further to inform practice and policy. So next slide. Yeah, so maybe to sum it up and probably give us a next step, even as we have been able to at least have a first step into understanding health policy research and to get into it. A next step would be just to reiterate, to define the problem at the place where you are, write a question about it, read papers on it, and then reach out to those people who you have been able to read their papers, and the process will be able to pick up from there, of course, if you are determined into it. But the takeaway message is the health system already has been shaping your career, and to get into it, to get into health research, health systems and research, health systems and policy research, it gives you an opportunity to be able to shape now the health system that you are, that already shaped your career. And with that, I remain yours truly, and even as I thank you for being able to attend the webinar. Over to you, Dr. Sevins.
Thank you so much, Dr. David. I think you've done this well, and maybe the last few seconds as you're presenting, I've just seen a comment from Dr. Nancy Njeru. Dr. Nancy Njeru is the Director for Healthcare Financing, Digital Health Policy and Research Standards at the Ministry of Health. And she says that she concurs. The Ministry of Health presents immense opportunities for learning and research because it is where real-world policy challenges emerge and solutions are tested. Those researchers will make the greatest impact, or who will make the greatest impact are those who identify a current policy or health systems problem and generate evidence that helps solve it. And thank you so much, Dr. Nancy, for sharing that with us, and also for just joining the session this evening. Maybe at that point, I want to assess the floor and see whether we have any questions or concerns from the participants. Kindly use the Q&A tab at the bottom of your screen to pose questions, and I think the speakers are excited and happy to respond to you. Maybe in the meantime, as you type your questions, I want to again just appreciate the presence of some of the leadership of PSK. I see Dr. Sami Masibo was joined as well. Doc, if you'd like to say hi, maybe this is the time I give you as we wait for questions to stream in.
Thank you, Manyala, and thank you, Victor, who is actually my boss in another world, for the nice presentation as well, and David as well. You guys have done justice to the topic. I think in very simple terms, research is like a blind date with knowledge. So usually you go in, and that's the beauty of research. You go in and you don't know what you'll find. So sometimes you make hypotheses that, even shock you sometimes. Just to appreciate the growth of pharmacy. And I think we spoke about this the last time we were talking about digital health with Clinton, that for a long time, digital health was being superintended or pioneered by people who are not even medics. Forget even about pharmacists, even medics. So it's one of those things, health system research and policy work, just the same as health economists nowadays. It's a field that has attracted pharmacists predominantly. And I think it's one of those fields that we should not be shying away from going into. It's relatively new, especially for health system and research policy. And it's very straightforward, actually. It's one of those fields that is very easy to go in. And I think Victor explained this very well for pharmacists, because we are affected by all the six pillars of the healthcare system. So I think from where I sit, I'm encouraging anyone who wants to go into that field. We have a lot of mentors in the space of health system and research and policy, and they're willing to mentor people around. Most of them are pharmacists, which is a very encouraging thing. Yeah, so thank you so much. I'm hoping we'll see a lot of us going into this research field. Just making sure that we we take it and own it and control it the way we've gone into health economics and digital health now. Thank you.
Thank you so much, Doc, and karibu sana. I know I've mentioned that it's the leadership, but my apologies. I should have said you are also a health systems researcher. And this is relevant input as well. Maybe for the next series of webinars, you would be sitting in the panel as well, just sharing more. I've seen two questions come in just as you're speaking, and I just want to read out one and invite both speakers to share. Maybe I'll start with a response from Dr. Mulelo, and then if Dr. David would like to add to that. So this is from Daisy Ogoya, who says, does health systems strengthening research pharmacy students are trained? I think this is in reference to pre-service training.
Sorry, come again. You broke up for a minute. I didn't get the question.
So we have a question that says, does health systems strengthening research also involve assessing how pharmacy students are trained?
Yes, remember I said it falls in any of the 6 pillars of WHO. So when you talk about the training of pharmacists, where will it ideally fall? It will fall under the health workforce component, right? Because this is where we look at the production, that is education and training, their internship, and how they join the health workforce. So for the particular work that we have been doing, maybe just to give some more context, is we are trying to generate evidence on the status of HRH in Kenya, because we are constantly saying that we have an inadequate number of doctors, we have an inadequate number of pharmacists, but as someone actually sat down and quantified this, yes, there's a gap, but where exactly is the gap? Which county is not employing the way it's supposed to be employing? We have something that is called the schemes of work that dictates the number of healthcare workers who should work in a particular facility. So you go to a level 4 facility and you say it should have this number of clinicians. But the number of clinicians you're proposing, is it proportional to the workload that they are handling? Because the truth of the matter is, not all level 4s are equal. Some handle more workload than others. So you're here prescribing that a level 4 should actually have 2 pharmacists, and maybe based on the workload they handle, it should have 4. So we're essentially trying to generate evidence across this entire life cycle. So when it comes to training, we want to look at the quality of training that pharmacy students receive. Is it proportional to what the market expects of them? I don't know if that answers the question.
Yeah, thank you. Thank you so much. I don't know if Dr. David would want to add to that, or if that is also...
Yeah, similar to,
sure.
I think, yeah.
All right. Thank you. Thank you so much. So an anonymous attendee says that an interesting survey in the Kenyan space for prison to take up is to survey the proportion of publications by pharmacists as compared to other healthcare workers in the Kenyan space. I think that's a recommendation from him. Stacy Moroki asks directly to Dr. Olpens, what has been the most fulfilling part of your PhD journey?
Thanks for that question, and allow me to mention I'm actually at the start of my PhD, and so far, perhaps the most, I'd say, rewarding bit is knowing that the skills and knowledge that I'm gaining at this point will enable me to contribute towards better NCD care that is affordable to people, affordable to the people who actually deserve the care. Yeah, so pretty much that is a rewarding thing to me. Eventually looking in the future that my work definitely will be able to inform policy and practice.
Thank you so much. And then she directs a question to Dr. Mudelo as well. When you mentioned pharmacy first model implementation, is that in relation to the public or private sector? And maybe as you even pick that up, I also want to just have you respond to another. So we have someone who's asking that you share an overview of the process of documentation and permissions needed for carrying out research in Kenya. Thank you.
Okay, thank you for those two questions. So I'll start with the one on research permissions. And I think it's one of the things that we'll also cover in detail as this series progresses. So first of all, you develop the conceptual framework, which is what will dictate what research problem you are trying to solve, right? Then you come up with an appropriate protocol for it. And once you've come up with the protocol, it undergoes what is called institutional review. So institutional review is whereby your protocol is looked at by an institutional review board or an ethics committee. And unfortunately, in Kenya, there are not many of them. You can find them at the major universities. That is, the University of Nairobi, I know, has one. Strathmore University has one. And I think Cambridge also has one. And once they give you ethical approval, you now have to get a research permit from NACOSTI. So once you have the research permit from NACOSTI, you also need administrative permissions, be it from the Ministry of Health or from the county governments, based on the kind of work you want to do. Because remember, there are various facets to research. There are those who will interview respondents. You need to get permission for that. There are those who will just roll out a survey and analyze the responses. So the degree of whatever research you're trying to undertake is what will determine all these processes. So some are more straightforward than others. Others require more administrative inputs. Then the second question was, kindly remind me the second question.
Dr. Stacy asks you to clarify. So when you mentioned the pharmacy first model implementation, was that in relation to the public or the private sector?
Okay, so that's an example I was using, and maybe also just to give some background to it. So the pharmacy first model is a model of primary healthcare that is being piloted in the UK, whereby they have a series of minor ailments that are being treated at the community pharmacy level. So one of them, of course, is the common cold. You have certain skin conditions such as chickenpox and so on and so forth. So they have a list of minor ailments that are treated at the pharmacy level. So what happens is you go to the pharmacy and they prescribe and dispense the appropriate drugs, right? Currently in Kenya, we don't have such a model, especially for the public sector. So now if you are to conduct research on implementation of such a model, economic evaluation will be a huge component of it, because you have to find out, will this particular model be cost effective for us, or will it mean that the patient or health insurance provider will end up paying more? Because remember, we have contextual differences. The UK is a high income country and Kenya is an upper middle income country. We were recently promoted, so technically we are no longer lower middle income, but there are still those contextual differences that you need to factor in when implementing such models. So it depends. It can work for both private and public, but at the moment, it's more prominent in the public sector.
Thank you so much. And I hope that suffices. I want to invite Dr. Olpeng to respond to this one. So can secondary data translate to a policy, or we just need the primary data?
Yeah, thanks. And absolutely, secondary data can and translate into policy, provided it is structured, it is of high quality, and it answers policy relevant question. For instance, you can do a secondary data analysis to be able to identify trends or emerging health issues. Could be, say, the rising burden of non-communicable diseases from a health information system. That in itself would be able to inform policy in the way probably resources would want to be allocated towards it, or even the way workforce would be structured towards tackling non-communicable diseases. Also, it could be able to, you could do secondary analysis to evaluate the impact of existing policies, and that could be using an already collected survey data, and then you'd want to give recommendations for even a reform of the existing policy to be able to inform a gap that has already been has been identified. So yes, I want to affirm that secondary data can definitely inform policy.
Thank you. Thank you so much, Daktari. Maybe as you take a breather, I just wanted to invite Dr. Masibo to also just chime into the conversation. So there's a question here that says, is there a document that provides information about the number of pharmacists and pharmaceutical technologists should be in each level of care, sorry.
Thank you, Manyala, and I want to recognize that Dr. Nancy is also in the meeting. I think you mentioned that she might have more accurate information, but there is a document. It's called the Staffing Norms and Standards for Health Service Delivery. It's quite an old document, the one I remember. So the health system used to be classified into 6 levels. Level 1, which is basically the community level, where we have the CHPs, so not really a pharmaceutical area for pharmtechs or pharmacists. And then level 2, which is the dispensary. The recommendation was not a single pharmacist, but 0 to 1 in terms of the pharmaceutical technologists. And this is only where that level offers pharmaceutical care. Level 3, which is basically a health center, would the recommendation was not to have a pharmacist, but to have at least one pharmtech. And then level 4, which is like a primary hospital, the recommendation is to have at least one pharmacist and at least one pharmtech. You'll also remember that there's a case that was involving PSK, and now the ruling has now said that at level 4, the superintendent must be a pharmacist. And then, of course, level 5, which are the secondary hospitals, or what some people call the county referral hospitals, multiple pharmacists and multiple pharmtechs. And then level 6, which is the national and tertiary hospital, also having multiples in that in terms of those 2 cadres. Now, the beauty of health system research, so just to take back this to the conversation that we are having, is that people are constantly researching on what is the best way to manage a facility. And I know there was a lot of discussions, and it was even the way facilities are classified was even shrunk down to tiers. So tier 1, tier 2, and tier 3. And there's a document to speak to that. I think maybe I'll look for it and share so that you can share with the participants through their emails or something. And then now currently there's a lot of discussions around whether we should even look at numbers when we are talking about these things. Because people have looked at the numbers, and sometimes even a very small facility could be having a very heavy workload, and a large facility that is staffed and has a lot of workers is not attracting patients. So currently, the way the ministry is looking at staffing is going to also involve a very dynamic process where we staff based on workload. So it will be the number of workers in a facility will be following the workload that it has, which is a more scientific way. It's a better way of managing burnout and managing health worker more efficiently. We have seen people now talking about consultants, for example, not being tied even to a facility and being a resource that is shared nationally. Yeah, so I just wanted to say that a lot of research, health policy and systems research is still ongoing, and even the ministry, the way it's looking at staffing and workload analysis, I think we are moving away from saying because you are this level, then you require this number of staff. We have always had this argument, for example, that nurses are always understaffed, and I'm yet to see an advert that has not had a nurse being employed. But when you do the analysis, for example, at the lower levels, you'll find that the number of nurses is less, not because they are less, but because they're doing every other person's work. So the nurse is the clinician, is the pharmacist. So if you employed those other cadres, then all of a sudden that number of nurses becomes sufficient. And that is the beauty of health system research, is just looking at the answer so that you actually solve the actual problem instead of just reacting to what is the perceived problem. Thank you.
Thank you so much, Dr. Masibo, for that context sharing. I want to invite Dr. Nancy to just share a remark, maybe build on that conversation. And I see she is also actively participating in the session. Doc, if you may, maybe a few minutes, and then we will go back to the session. Thank you.
Thank you. Thank you very much for the opportunity. When I saw the session, I was very excited to join, and I've learned a lot. I think this is a very important discussion at this point because it really opens members' minds into the opportunities in policy. And I was very interested, especially because our directorate is dealing directly with policies. And right now, if you look at what we are doing and the reforms that are happening in the sector, they have been informed a lot by those who have done a lot of research. And just to appreciate HERU, Health Research Unit of the Kemru Wellcome Trust, because this is the one institution that has informed a lot around the health financing reforms in the Ministry of Health, and not just health financing reforms, but also other areas. And most importantly, during COVID, modeling and all that, what you were able to do. So when you speak about policy, I want to really just mention to members that this is a great opportunity. And even when you have an interest, some people, you can even apply for attachment within the Ministry of Health. Sometimes you may find yourself getting an opportunity. That's an important message to communicate because I also know there are those that will come through the Public Service Commission, but also as a pharmacist who has finished an internship, you can be able to apply for an attachment. Some have come through and they have gone to very bigger areas. And yes, we do work a lot with the research and academia. And if you look at currently what we are doing at the Health Benefit Package Advisory Panel, it is linked to an academic institution, which is the University of Nairobi, the Center of Epidemiological Modeling and Analysis, where they are doing a lot of health technology assessments. I can attest to you that currently we are handling 117 interventions that are going through health technology assessment. And in May this year, was able to have an HTA program approved in my directorate. We call it KITAP, Kenya Health Interventions and Technology Assessment Program. So we are doing a lot of research with academia to inform policy, what we call evidence-based decision-making and interventions that are going to the benefit package. So this was really a great session for me. I really appreciate what you're doing and welcome you to work together. If you need to join the health technology, HTA, TWG, I'll be able to help you get in because it's an exciting time for the country. We also have financing TWG. We are reviving research TWG within the ministry, and all this happens. So it's an interesting area. In terms of human resources for health, I've shared the norms and standards for HRH. It's a very old document. I think it was done in 2016. It's been challenged a lot by many, especially because the policymaker was feeling it was bloated. Of course, when you go to do some of these policies, sometimes it's not, there's a lot of interest. For me, if you look inside, you might see somebody called a dispenser, pharmaceutical technologies, pharmacists, then you see a dispenser, then you're wondering, who is a dispenser? Or even pharmaceutical persons or professional involved in this process. So sometimes, so that document is under review. There's a lot happening under HRH. It is one of the big priorities of the current government. They have 4 big priorities, which is HPT, digital health, health financing, and HRH. So HRH is getting a lot of interest. And if you have seen the tree, there's the Human Resources for Health policy, which is going around. So make sure you give an input. But I think there's so much happening. And when you do research, you can really solve a lot of the problems that the government is having. So we embrace research in a very big way, even in my directorate and across the Ministry of Health. I think that's what I wanted to say. I can't say much today because it's not my day, but I'm really impressed by this session. Back to you.
Thank you so much. And we are, of course, delighted that you joined us as a participant and you've had the opportunity to also share a remark, a bit of context as well on the work that the directorate is doing. And it's also good to hear that you're open to, of course, working with us. And I think that's something that excites us as a society, and even the sectoral committee that has planned this and organized this series of engagements. And thank you so much. So maybe at this juncture, I just want us to do one last move take. So I switch towards the end and to invite Dr. David and Dr. Victor to share their opinion on a concern that has been raised regarding how many of the research works that are not readily implemented within our healthcare systems. Of course, this is more of your opinions, personal opinions, based on your observation, that why are many of the research works not readily implemented within our healthcare system? Anyone wants to go first?
Yeah. This in my observation, I think research is not always implemented because generating evidence is only one part of the process. The findings that come out of any evidence base first have to align to the policy priorities that are there at that current time, and also they must be feasible to the resources that are available, and they must have been able to garner the support of the decision makers through, and this is garnered through the process of doing the research itself. And you find in many cases, most research usually deviates from this, and that's why it ends up not being implemented. But as but if for many of the research work that has been able to speak to the priorities and all this, you'd find it would be easily adopted to inform policy and practice. But I'd wish to invite Dr. Victor to maybe add more.
Well put, Daktari. Just to refer to my presentation on how we move from problems or opportunities to policy and impact, you remember when I said the last 3 steps, that is influencing policy, implementing solutions, and improving outcomes, are the most difficult. That is where the problem lies. That is why most of the research work will not necessarily translate into impact, and it's actually a science on its own. There's something called knowledge translation, which is a communication science that seeks to bridge that gap between research and evidence generation and how it translates to impact. Because remember, most of these policymakers are not healthcare workers, they're not pharmacists like you and me. They're essentially not affiliated with the healthcare sector, most of them, that is. So how do you show them that whatever is ailing the health sector is relevant to them as a policy maker? And how do you ensure that it aligns with their priority in terms of leadership and governance without distorting the message? So it's usually a very tightrope to walk, because you essentially have to package the findings, no matter how unpalatable they are, in a manner that the policymaker is willing to listen, accept, and act on them. So it's a really tight field. And like I said, it's a science on its own, and you have so many people working in that space, both at Strathmore and at Cambry Welcome. But yeah, it's actually a real challenge.
Yes, thank you. Thank you so much, Dr. Mulelo, Dr. Olpengs, for your enthusiastic, of course, feedback. I see a lot of positive remarks, that the session has been a good one. There's a nice presentation, very good presentation, and informative presentation. I think this one was a hit. Maybe at this juncture, allow me to just switch up to share some brief announcements that we have. And one of them had been alluded to at the beginning of the session. There's a conversation around online pharmacies. So should you buy medicine online? The truth no one talks about. And one of the speakers, Dr. Victor Mulelo, is a guest appearing in this. This is premiering at 1 p.m. on Friday. So kindly watch out for this. Dr. Sami Masibo as well is featuring in this episode. This is episode 4 of our podcast. And also just want to highlight that we have some recent conversations we've had before the episode that is upcoming. We had one with and her health, that is an influencer, and also someone I'd say is a conversation shaper on how the public, engages or the sort of the medication seeking behavior online. And we also have an expert in Dr. Weremu Mbogo, as well as Dr. Nicola, who is a specialist in diabetes management. And that conversation began a while ago while Murugemoni shared her journey on weight loss. Something that I would want also to invite you to just catch up with before our next episode launches. But even then, we began with a very fruitful conversation on whether, I know we've spoken about the staffing norms. So whether, of course, the public is gambling with their health and whether they're trusting quacks. Yeah, so I'm sharing this. These are 4 episodes, 4 parts that we've so far done in the last few weeks. Conversations that are shaping the public, knowledge and education with regards to their healthcare seeking behavior. And we're inviting you guys to just see. We have this episode up on YouTube as well as Spotify for those who'd like to listen to audio. We have another webinar, not really a webinar, but a CME. This is a hybrid session that is happening at the University of Nairobi with support of the University of Washington. It's a lecture by Dr. Jashvant, who's a professor of pharmaceutics, the School of Pharmacy, University of Washington in Seattle. And we are working closely with the School of Pharmacy, University of Nairobi to have this. So this is happening on the 6th of August. You are invited to participate. Once we have the link generated, we'll be sharing that in the member platforms. Again, something for your noting is that the Senate has called for submission of memoranda for the Quality Healthcare and Patient Safety Bill. We've been collecting inputs from the membership, but we're also encouraging you to share or submit individual memoranda, and that is the circular. The same happens for the Kenya Artificial Intelligence and other emerging technologies policy. Something that you need to look out for. So the deadline for this is the 4th of August as well, and we encourage you to show up and participate. And of course, this is a recent thing. We are working around the clock to ensure that our website is up and running. However, our members portal is up and running. So if you need any services that is available on the members portal, please do not be afraid. But just in case you need support again for other resources, feel free to reach out to communications@psk.or.ke and we should be able to support. And that is it for this session. We encourage you to engage with us, interact with us online. We have a very robust social media presence across multiple platforms, including our most recent one, which is on TikTok at PS of Kenya. At this point, again, just my appreciation for the speakers, for the other members of the panel, Dr. Sami Masibo for joining, Dr. Nancy Njeru for supporting and sharing your remark, the committee for doing the hard work behind the scenes and delivering this for us, and looking forward to more of the series that is upcoming. Good evening and good night.